Welcome to another Lunch and Learn at the Putnam County Library System. Today we'll be learning about ABA with Audra Stangenberg.
Good job. So, like I told her, with a name like Audra Stangenberg, you can call me whatever. I'll answer. Everybody butchers it. It's no big deal. It's okay. So today, to give you a heads up, the PowerPoint I'm pulling from is one that I typically give to like pediatricians' offices and things like that to tell them about our company and what we do. So I'm going to kind of go through parts of it, but I'm not going to use the whole thing because referrals and things like that, that's not really something y'all care about right now. So my name is Audra Stangenberg. I'm a BCBA, which stands for a Board Certified Behavior Analyst. And I work for a local company here called Global Behavior Education Alliance. We're actually all throughout the state. We provide behavior therapy services in clinics in Kentucky, Nashville, Clarksville, Manchester, Cookeville, Jackson, McMinnville. We have a couple more on the horizon and a few other places getting ready to open. And we provide both clinic and school-based behavior therapy services, primarily for children with autism. We also use family and parent training. All of these different things come into play when you talk about applied behavior analysis. So, the meat of why we're here, what is ABA therapy? Well, first, ABA stands for Applied Behavior Analysis. It's a scientific study. It's rooted in research, long-standing within the science community, rooted in behaviorism. But essentially, it is behavior therapy for people with autism or other developmental disorders. And the goal of the ABA is to increase an individual's skill development while also decreasing maladaptive or challenging behaviors. So within that, we look at what, yes, sir?
Would you rather us wait for questions after the introduction?
You can ask. Yeah,
So what maladaptive behaviors, what does that
Okay, so maladaptive, it's a big fancy word, but it's challenging or sometimes dangerous. Not beneficial behaviors ultimately. So I don't know how much each of you knows about autism or other developmental disorders, but typically we see significant skill decreases, developmental delays, things like that, and that often comes across with also these challenging behaviors. So that may be something like screaming or fighting, aggression. It could be self-injury, them injuring themselves. They have a lot of underlying sensory needs that come into play. And then we also look, ABA specifically looks at the environment around them and how we can change and manipulate that environment to help them learn how to communicate and how to express themselves without engaging in any challenging behaviors. Okay. All right. So this is where it gets into like the referrals and how we get patients and that kind of thing. Ultimately, they have to have a referral from their doctor. And then we'll walk them through the process of getting their initial evaluation done with us, all of those types of things. It bills through insurance. It is a healthcare service. ABA is overall so much bigger than what we do in the clinical setting. It's used by corporations with organizational behavior management. It's called OBM. It's even used by like video game developers. Learning how reinforcement, which is rewarding somebody for their behavior, helps them do that behavior more. So it plays into everything that's used in education. They may just not know what the term is and how they're using it. Because I know for me, my background, I was a special education teacher for 9 years before I became a BCBA. And when I started in my grad school work, she would say things and I'd go, oh, I already do that. I just didn't know there was a word for it, right? So it's about learning to specifically understand behaviors and what causes behaviors to happen and what can make those behaviors either happen more or happen less, depending on what it is. So we're never just looking at it like, say, self-injury. We have a kiddo who's engaging in headbanging. So that's a really severe form of self-injury, right? So we're never just looking at how can we get them to stop doing this. Obviously, we want them to stop doing this. We're also looking at why. Why are they doing this? What in their environment, what internally, what's going on that's making them do this. So we're gonna rule out medical We're gonna make sure the physicians check them over. Are they having migraines? Do they have a toothache? Make sure physically there's nothing there that could be causing this. We're gonna look into occupational therapy to come alongside with us to work on their sensory needs and those underlying things that could be causing some internal struggles and help regulate them. And then we're also gonna look at their environment and what could be causing within that environment. So are they only doing it when there's loud noises? Are they doing it when we give them work to do? And suddenly they have, they go from happy to banging their head. So what is happening before, during, and after these behaviors? But we're never just working on decreasing, we're also working on teaching them replacement skills. So a lot of times, especially with autism, we see a language delay. A lot of autistic individuals have significant impairments when it comes to learning to speak and to communicate. And we work with them on learning to functionally communicate. For some people, that's verbally. Some people, it's sign language. Some people, it's images. We have a lot of clients who use what's called AAC devices, which is assistive communication devices. It can even be apps on an iPad that they use. They can press the buttons and it speaks for them. So they're learning to communicate, and a lot of times what we see is as they learn to communicate, those behaviors decrease. Take a moment and think about you're dropped off in another country, you don't speak the language, you have no idea how to communicate with these people, none of them speak or read English, you have no way to communicate, I'm hungry, I need to go to the bathroom, it's too loud in here, right? You would start to get anxious, you would start to have behaviors that would manifest or come out, right? Because you were getting so upset. So language and communication is power. Teaching them to communicate is, it's such a passion of mine. Helping people who struggle to learn to get their needs met and their thoughts and their feelings heard, it's such a difference that it makes in these people's lives. All right. So, like I said, that's more like the clinical, insurance-y side of how we come around to doing services. And if you have questions about that, feel free to ask me after. So, once they begin services, they'll start working with what's called a registered behavior technician, or an RBT, in the clinic or school setting, depending on what their needs are, what their insurance covers, as well. And then the RBT is supervised by somebody like me, a BCBA. So the RBT works directly with the individual, and then I supervise them and also come alongside and work with the individual at the same time. So think of it like if you're in a classroom, I don't know how many of you are super experienced with current classrooms, but you have your teacher, then you have your teacher's assistant. So the RBT is like the assistant and the BCBA is like the teacher in that structure. So the teacher is designing the learning program, training the RBT, making sure the data is being taken correctly so that we can monitor and see how things are changing, seeing if what we put in place is working, so that we can make changes quickly, because we want them to meet these goals as quick as possible, right? We want them to communicate and to learn and to gain these skills as quickly as possible because they're beneficial for their life. BCBA will also work with the family to teach them the basics of ABA and to identify ways the skills and techniques being used in the clinic or school setting can be implemented at home. So that's another big passion of mine, is the family training aspect of it. I love to have the parents come in, we sit down, what do you know? What do you know so far? How's it going at home? What does this look like there? Because we're a clinical setting, right? We're not exactly like home. We can try, we can work towards making it as close to the home setting as possible in our sessions, but it's never gonna be exact, right? So working with the families on, what barriers are there at home? We work long hours, we're hardly ever home with them. They're with their grandparents or, those types of things. Okay, cool, can grandparents come for training sometimes too? And figuring out and meeting them at their level, just like I meet their child at their level, so that they can feel empowered to help their child learn these skills at home too. So, as a BCBA, I'm continuously evaluating their progress and needs to identify what skills they've mastered, any program changes that are needed, and effective interventions. That also includes attending workshops, doing research, reading additional research materials, because sometimes I have kids that come along and I'm like, whew, I don't know. That's a new one, or I'm not, I've tried all my bag of tricks and I've manipulated things and things still aren't working like they need to work yet. So I turn to the research and I'm like, well, anybody else seen this? What's going on here? Any new ideas? In science, especially in ABA, it's a relatively new branch of science. There's constantly new research being done, new techniques are being explored. It's constantly changing, which is good. If you were to Google ABA, you would see that in the past it's had some really unethical practices that we don't do anymore. Especially in my practice, I don't do things like shock therapy or anything like that. So we talk a lot about not just consent from the individual, but their assent as well. So their willingness to participate in the session. We look at the goals we choose to make sure that they are what's called socially significant to the individual. So they're making that individual's life better. Not necessarily that the greater public would see it as significant, right? It's something that's significant to that individual. So making sure that we're being ethical in our treatment and our decision making and all of those things is hugely important in modern ABA, because ABA had a bad rap for a while. All right, so what does a day in ABA therapy look like for a kiddo? So at our clinic, we have kids as young as around 3, all the way up to 14, 15 at times. Any older than that, and we typically, we can still do services, but it's gonna be through telehealth or at home or out in the community. So learning community-based skills of how to buy groceries and how to order your food and those types of life skills out in the community. Because we're just not set up to have, 18, 19-year-olds and 2-year-olds at the same time, right? Raises some concerns there. So what we do is highly personalized for each child, each individual, each client. We look at them as a singular person, right? So since pretty much all of our clients have autism, I had a professor in college who would say, if you've seen one child with autism, you've seen one child with autism. It presents so differently. It's a spectrum, it's wide, right? So we have to look at it individually. We use the research. It informs our decision making. It informs how we understand behavior and how behaviors work. Yes, sir?
How many years of research with autism do you all have?
So like within ABA as a whole? And the first journal of applied behavior analysis was published in the 60s. So it goes back even before that, but it starts to get a little murky because the diagnosis of autism hasn't always been around. They call it other things, things like that. So, and even the diagnostic criteria of what autism is constantly evolving as well. As recently as the 20-teens, they updated it and changed what it meant to have autism.
Okay.
Yeah.
So we have around 60 years of evidence or research pertaining to autism.
Specifically, yes.
Development.
Yeah.
So when did the prevalence of these programs start to come into the
90s?
The 90s?
The 90s, it starts to take off. There starts to be more research and acknowledgement within the medical community, not just the scientific community, that this is a beneficial way for people to learn. It's considered the primary treatment for autism. We're never trying to cure autism. So you think treatment, you think trying to cure it, right? We're not trying to cure it. Right?
This will be my last question.
You're good. Ask as many as you want.
I was going to say that, okay, so it's been around for 60 years, yet we only have 30 years of practical knowledge regarding it.
We have more than 30, but 90s is when it really starts to take off. So they really start to have more strict qualifications as to what is a BCBA, right? So to become a BCBA, I had to get a master's in applied behavior analysis. I had to do an additional 2,000 hours of field work, and then I had to pass a board certification exam. And then around 2010, 2015, states also started requiring a medical licensure to practice as a BCBA, so Tennessee is one of those. So then I had to apply for that. So I had to hit all of those qualifications before I could say, I'm a BCBA, I can serve your child, right? So,
Okay.
no, you're good.
You said so. This is a fairly new field of study, is
Oh,
what
yeah.
you're saying.
Mhm.
So, where do you see this field of study progressing into the future?
That's an excellent question. I don't know that I've necessarily thought that far, to be honest. I'm still what I would like to call a baby BCBA. So I just finally jumped through all of my hoops last fall. It was about a 3-4 year long process. I started during the pandemic, and started, working my way through all of those steps. It's ever growing and ever changing. The ways that we used to teach, so in the 90s when it really, starts to take off, starts to get popular, there was like the Lovis method, which was a lot of sitting at the table for 8 hours and just reinforcement. Here's your Skittle. You did it. Here's the Skittle. That type of thing. And we don't do that like that anymore. So it's constantly evolving as we understand autism and individuals, ethics, trauma, all of those types of things so much better and take it all into account. So, any more questions?
I did.
You're good.
The methods for these types of studies that you are doing, like you were saying with the basically maybe you use cups or something such that to do their I guess spatial or motor.
Yeah, like matching colors or something like that. Yeah.
So would the process, would it use something such as classical conditioning, would y'all say? Or?
Yeah, it ABA builds on those fundamentals of behaviorism. So you've got classical conditioning and those types of things, and it builds on that knowledge that they developed then, and now we're applying it, right?
Okay.
So it's not just behaviorism. We're not talking about rats and dogs and pigeons and things like that anymore. We're talking about how we can apply what we understand of behavior to making a socially significant change. So that's that important change to that person's life. Okay.
Does a child ever outgrow autism?
No.
Okay, I'm asking for a reason.
Oh, you're good.
I have a granddaughter
Uh-huh.
that was diagnosed with autism at the age of 2.
Mm-hmm.
She's now 7.
Mm-hmm.
This year, they took her IEP away from her.
That gets a little bit tricky. So, coming as a former special education teacher, to qualify for an IEP, it has to have an educational impact. So, if
She didn't start talking until she was almost 4.
right, so she's progressed tremendously,
Yes.
right? Yeah. So, an individual doesn't outgrow autism so much as they learn to cope, right? They learn those coping skills that they need. They learn that functional communication, like she did at 4. She started to talk, right? And now she's 7. And if there's not a significant educational impact, is what they would say. If we're not struggling academically, we're not struggling behaviorally in school.
Well, she still has problems with the loud noises,
Right.
sensory things.
Yes, absolutely. Yeah, and that's a lot of times what you'll see, even when that communication and stuff comes back, they can do those things now, they're still gonna have some of those sensory needs, organizational needs, things like that. But in a school setting, there's something else called a 504 plan that's available that is for individuals who have a disability but don't necessarily have that significant educational impact. So they kind of work simultaneously together, one or the other type of thing. That's where that can come into play.
Thank you.
You're welcome. Okay, so highly personalized, right? Natural environmental teaching. That's where I was talking about. Instead of that constantly sitting down and doing here at the table, because this is what I said we needed to learn, we're incorporating their goals into naturally occurring opportunities. So if a kiddo is working on tolerating waiting, we're not gonna make them wait at the table. We're gonna be like, oh cool, you wanna swing? Awesome. We're gonna set a timer. We can ask our friend to swing. and we'll have a timer, and we're gonna wait here because we're motivated to get that swing, right? But if I engage in those behaviors, I've gotta go somewhere else. I can't get the swing. So they learn in that natural environment of, I can wait, it's okay to wait. We may start at 10 seconds, we may start at 30 seconds, or they may be able to wait 15 minutes for their turn on the swing, right? It just depends on the child and where they're at. That's where that goes back to highly personalized, right? Another thing I've talked about already, functional communication training, it's my favorite. I love it. So, I mean, I've already talked about it, but often the delays in language have a huge impact on those behaviors that we're seeing, those maladaptive behaviors, right? So, by teaching them and focusing on helping them learning to communicate, then their other needs and wants and skills can start to come along, right? And then discrete trial teaching. So this is the sitting at the table type of stuff, right? Because there's some stuff that's just best learned at a table. And there's some individuals who learn best this way. So we're able to teach them here. So within functional communication training, say I have a client who really struggles with remembering vocabulary, right? Acquiring new vocabulary words, even things simple as like chair, table, pencil, right? I'm not able to say, go sit in the chair and pick up your pencil, and them to be able to do it. So showing them pictures, this is a chair, this is a chair. It's using their AAC device, chair, yeah, that's a chair. Good job, woohoo, you want some tickles? You know, whatever it is that they enjoy, right? They're getting that after they have, you know, a correct answer. And woohoo, yeah, we're celebrating that, you got a correct answer. So, okay, they've got the picture. What's this? Chair. Awesome, yeah, it's a chair. Well, what about, you know, that chair over there, is that a chair? So we're building on these skills that they may have started learning in DTT, is what we call it, and building upon that so that it becomes something we can do in the natural environment, so that they, what we call generalize, where they expand it across, you know, when you ask them, what's this? They can say chair, right? But they don't know you. They just know that that's called a chair, and they know what the words, what is this, means for them to do. All right, any questions? All right, so this is just about our services that we offer there at the clinic. We've now got speech therapy, OT, we have an on-site nurse, we have Spanish language translator, and we also offer diagnostic testing for individuals with suspected autism. He doesn't just diagnose autism, also ADHD and other disorders as well, because he is a neuropsychologist. But if they do have to have suspected autism to qualify to get a diagnosis with him. Okay, so then I've got one more thing I'd like to show you, if I can get it pulled up. Here we go. So, this is basics of what is applied behavior analysis, right? So we work with reinforcement and punishment. So reinforcement just means it makes a behavior happen more. It can be a behavior we want, it can be a behavior we don't want, right? So if I cry and my math homework, I suddenly don't have to do it, what am I gonna do tomorrow? I'm gonna cry, so I don't have to do the math homework, right? So that crying behavior was reinforced because I did it again, I did it more, right? Punishment, a lot of times in our day-to-day language, we think, oh, well, that's a bad thing. It's not always a bad thing. It just means the behavior happens less. So it can be, nobody looked at me when I told a funny joke in class. Like, nobody laughed. Oh, well, okay. Nobody, I didn't get spanking. I didn't, nothing like that happened to me, right? But I may not yell out in class and then a joke again, right? Because nobody laughed that time. So it's all about shaping the environment to affect the behavior. It can be positive or negative. Positive just means we're adding something. Negative just means we're taking something away, right? So you can have positive reinforcement or positive punishment. Say I like TikTok. And I get lots of comments on my TikToks. I'm gonna make more TikToks like that TikTok, right? Because I like that. But if I don't like attention and people are like, yay, I love that, I'm gonna be like, whoa, not doing that again, don't like that, right? So then that same type of comment or interaction can become a punisher, depending on the individual and the setting, right? So, positive punishment, adding something to decrease the behavior. Negative reinforcement, taking something away to increase the behavior. So that's the crying and math example. And then negative punishment is taking something away to decrease the behavior. So getting grounded. For my son, it's loss of video game time, right? So if he gets in trouble at school, he knows, not gonna get to play a Switch today, right? So he's less likely to get in trouble at school. So this is just some overview of how we start an ABA to identify in that environment how we can change and shape these behaviors. So we identify what the behavior is. We figure out exactly what it is, exactly what it looks like. We're very descriptive. We're very, this is exactly what it is. This is exactly what it isn't. So say it's hitting. We're working on the kid not hitting people. Well, they went to hit a balloon and accidentally hit someone, right? That happened to be right there. And that's not an example of hitting. That was an accident, right? They were going for that balloon. They weren't going for that individual, so we're not going to count that. But they walk up and smack someone. That counts, right? So in that description, we're going to be very clear on what counts and what doesn't, so that every individual who's measuring it knows what they're looking for. And then we're going to observe it. We're going to write down what happened, how often it happened, how big it was, how long it lasted, what it looked like, those types of things. And then we're going to use all of that to find the function. So we're going to look at what happened before, right before the behavior. We call that the antecedent. Then the behavior, and then what happened after. We call that the consequence. Again, consequence is not something negative. It's just whatever happened after the behavior. So we call it the ABCs of behavior: antecedent, behavior, consequence. And then from there, we're able to make a plan and track and all of those things and adjust as needed. So we consider there's 4 functions of behavior. There's attention, escape, access, and sensory. So attention, behavior doesn't get attention, right? You like people to look at you, like people to laugh, you like people to interact with you. Escape, I hate math. Do anything to get out my math homework as a kid. Anything, right? So those were escape maintained behaviors. So access, behavior done to get access to something. It can be a preferred toy, it can be a preferred person, it can be a preferred anything as long as it's a something, right? And then sensory, typically these are behaviors that are done even when no one's around, when there's nothing to do. So a lot of times with people with autism, see things like hand flapping and things like that, and we wouldn't try and correct that. Because doing this doesn't hurt anyone, right? Doesn't hurt anyone, it's fine. Then we call that a stim, but that's a sensory behavior. Nothing in the environment is controlling it. It's an internal thing that's making that behavior happen. So like for me, if I'm just sitting there scratching my head like this, that's a sensory behavior. I'm gonna do it when I'm alone, when somebody's there, when I'm thinking, I'm gonna scratch my head, right? So that's a sensory-based behavior. So then there's the ABCs that I talked about. And then how ABA looks different for everyone. It's completely customizable. All right. Anybody have any questions?
Okay, so I know a little bit about the ABCs and about positive and negative reinforcement.
Yeah, I saw you nodding when I was talking. I was like, he's got it.
I don't know if I got it, but I know a little bit about it. But there's a term that y'all didn't use on there, and it kind of made me happy. Y'all don't use extinction, do you all?
Extinction is a last resort.
Okay.
Extinction is incredibly hard to actually do correctly, because to put a behavior on extinction, it has to never, ever, 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 ever get reinforced, right? So if it gets reinforced at all, then that's called intermittent reinforcement, and that is the strongest way to reinforce a behavior, because if it happens sometimes but not all the time, then if I keep doing it, at some point somebody's going to give me what I want, right? So that's where differential reinforcement comes in. So that's going to be reinforcing the behavior we want to see, or the even just the absence of the behavior we don't want to see, right? So as long as you're not engaging in this dangerous behavior, then we can be having fun, right? As soon as you engage in this dangerous behavior, no more fun until we're safe again, right? So that's differential reinforcement. There's various types. You can get into all those another time. That gets real deep into behavior analysis, like you're studying for the BCBA exam type of stuff. But extinction it's one of those like old ABA type of ways. Occasionally it's needed because we don't want kids to engage in headbanging, say. So we don't want to reinforce that, but we also want to target it and make sure it doesn't happen through antecedent behavior interventions, so things we can do ahead of time, right? And not just rely on that, oh, it's already happening, so now we can treat it. We want to treat it ahead of time before it ever happens, so we don't risk accidentally reinforcing it, right? Or injury in that case. Any more questions? That was a great question, by the way.
Well, I understand my granddaughter a little better now.
Oh, I'm glad.
I'm glad I came.
I could talk about autism all day long.
She doesn't live here. She lives in Clarksville and
Okay.
they're ready to move to El Paso, Texas.
Okay, all right.
Her dad's in the Army and they get specific assignments because of her.
Right. Yeah, to make sure she can have what she needs. Yeah, very good. All right, any more questions? All right, I think we're good. We're good. We're done.
Well, great. Thank you everybody for coming today, and thank you for this very interesting topic. And we'll see you again for our
And
next
I'll hang
lunch and
out for a
learn.
few more minutes in case anybody has more questions.